Ladies and gentlemen, welcome to today's webinar. I'd now like to turn the call over to Karen Van Landahan. Please proceed.
Good afternoon, everyone, and Happy New Year. Welcome to the Association of Maternal and Child Health Programs webinar, Opportunities and Strategies for Improving Preconception Health Through Health Reform. My name is Karen Van Landahan, and I'm a Senior Advisor with AMCHP. We're really excited about this national webinar. As many of you know, there are many important efforts occurring at the national and state levels on improving birth outcomes, including this work that we're doing funded by the generous support of the Kellogg Foundation. This webinar is an outgrowth of work that AMCHP has been doing for over 2 years, providing technical assistance and resources to state Title V maternal and child health programs and their partners in state Medicaid agencies, state organizations such as the March of Dimes and provider groups and others, to build and strengthen efforts to improve birth outcomes with a particular focus on preconception health, but not limited just to that. We're working with states in 3 core areas, just by way of background. We're working with them to examine and explore opportunities to improve birth outcomes, particularly preconception health, through changes to the healthcare delivery system that's brought by both the Affordable Care Act and also through health reform changes in general. Second, we're working with states to strengthen partnerships between state Title V maternal and child health programs and other key stakeholders such as state Medicaid agencies, providers, community health centers, and local health departments. And then third, we're really working closely with states to try and identify specific strategies for financing of preconception health, particularly for Medicaid-supported births. Our work in this area is really multi-pronged, but it includes work with 6 states as part of an action learning collaborative. And because some of the content that we presented in that work was so well received by the ALC states, we wanted to feature some of that content, including one of our own action learning collaborative states, Oklahoma, in this national webinar. It's clearly a topic of interest as we have had over 900 participants register for the webinar, so we're just really excited about the interest in this topic. Finally, to provide some context and content that you all know, but as you know, the Patient Protection and Affordable Care Act provides health insurance coverage to millions of uninsured adults, or will so in 2014, and it also provides states with new tools and resources to improve access to health care for women, particularly those who are low income and uninsured. Under the ACA, several provisions have the potential to help states with improving their work on birth outcomes. And these provisions include requirements for insurance coverage, the Medicaid expansion for states that choose to do that, insurance market reforms, health system reforms such as investments in health homes, and preventive service requirements for women. In addition to the ACA, we know that state Title V and Medicaid are longstanding programs that have provided important coverage and supports to women and their families, particularly those who are low income. These resources and how states can and are using them and the opportunities and challenges in advancing this work will be discussed today. So I'm going to turn this over to Carolyn McCoy for some further comments and also to talk about some of the logistics of the webinar, and then she's going to introduce our presenters. I just want to take a brief moment to thank Carolyn McCoy for her work on organizing this webinar and also to recognize some of our other staff at AMCHP, including Pia Hansen, who have been working hard on this project. So Carolyn McCoy, want to take it over?
Yes, thank you, Karen. Hi, everyone, and good afternoon. Thank you so much for joining us. I want to just run over some quick housekeeping reminders for you all before we get started. And hopefully, if you're hearing me, the audio is being broadcast through your computer. And if you know of anybody that might be having audio difficulties, we have a phone number for them to call in if they can just type in using the chat feature on the webinar. You'll see that down on your lower left-hand screen. And please direct those comments to the chairperson, and we'll get back to you as soon as we can. We have somebody here standing by to help with that. We've left a good amount of time at the end for questions and answers. However, during any part of the webinar, you're welcome to submit your questions through the chat feature, which is how we're handling the question and answers for this webinar. So if you have a burning question, feel free to just type it in and direct it toward the chairperson and send it our way, and we'll collect those for the end where we'll have a generous question and answer period. And once again, please just make sure you address it to the chairperson and then it'll come to us. We've had lots of questions asking if the webinar is going to be recorded, and it definitely is being recorded. And we'll also be posting the full webinar with the slides and the presentation with the audio recording to AMCHP's website at www.amchip.org in about a week after this broadcast. So please stay tuned. You'll also receive an email letting you know where to find the broadcast. Additionally, following this webinar, you're going to receive a link to a brief survey. It will really only take a few minutes, and that we ask you to take a moment to please offer some feedback to help inform our future efforts and this current webinar. And lastly, like I mentioned before, but you'll receive an email with the link with a full set of slides and the recorded webinar with the link to the recorded webinar. So be sure to look out in your inboxes for that. And then without further ado, I'm going to turn this over to our presenters, but I'm going to run by who's presenting quickly right now. We have Usha Ranji, who's the Associate Director for Women's Health Policy at the Henry J. Kaiser Family Foundation. We have Kay Johnson, who's the President of Johnson Group Consulting Incorporated. We have Jill Nobles-Botkin, the Director of the Perinatal and Reproductive Health Division at the Oklahoma Department of Health. And we also have Shelley Patterson, who's the Director of Child Health at the Oklahoma Health Care Authority, which is Oklahoma's state Medicaid agency. And without further ado, I'm going to turn the presentation over to Usha Ranji from the Kaiser Family Foundation, who will provide us an overview of coverage for women's and reproductive health in the United States and what we can expect from the Affordable Care Act. Usha, please take it away.
Thanks so much. Thanks so much, Carolyn, and good morning, good afternoon to everybody on the phone. It's great to have so much interest in this topic. The Kaiser Family Foundation is a nonprofit, nonpartisan organization that conducts analysis and research on health policy issues. Health reform, Medicaid, along with women's health are core issues for our organization. So I'm really pleased to have the time to talk with you today. I think we've all been hearing a lot about the Affordable Care Act over the past couple of years, and so today I want to kind of go over what I think are the key issues for women and women's health in the ACA and review their impact on reproductive health and preconception care, and specifically looking at things like preventive services, the Medicaid program, and reforms to the private insurance market. So just to go over a little bit about what has happened so far, many provisions of the ACA are already in place. I'm not going to go through each one of these, but some of the big ones and the notable ones that we've heard about are the extension of dependent coverage up to young adults age 26 to remain on their parents' health insurance policies. We no longer, the prohibition on denying coverage to children with pre-existing conditions, some of the premium review and rebate programs, and the no cost sharing for preventive services in new private plans and Medicare. And I'm going to talk about that in more detail. But still, the major coverage expansions and significant reforms under the ACA are to be implemented over the next year. We're all looking ahead to just under a year now of January 2014. And so the kind of major issues that we're looking for are the individual mandate when health insurance coverage will become mandatory for most people, the establishment of health insurance exchanges, the expansion of Medicaid programs in many states. Some states have already moved ahead and are doing that. And you know what we've seen, especially in the past couple months since the election, is a lot more guidance from the federal government on all of these issues, and really states have many, many decisions to make over the course of this next year. So what you see here in this chart is a kind of a schematic of how the health insurance expansion is ideally to work over once it goes into full effect. So health insurance coverage expansion was really kind of the heart of the ACA. And so what you see here is the pie chart on the left is a portrait of health insurance coverage today for women of reproductive age. We have more than half covered under employer-sponsored coverage. The Medicaid program, very important for this group. But still, despite the patchwork of programs, we still have about a fifth of young women who are uninsured. Over on the right is what we've done is looked at the income distribution of the uninsured population here. And you'll see the kind of federal poverty level numbers that we've chosen there are really based on the thresholds in the ACA for expanding coverage. So the first thing to know is Medicaid. The Medicaid program is really the foundation for expanding coverage. Right now, Medicaid is determined in states by both an income threshold as well as categorical eligibility. That is, people need to be below a certain income threshold as well as fall into one of the Medicaid categories. That is, pregnant women, dependent, or having dependent children, or having some sort of disability. Under the ACA, the Medicaid program broadly will be expanded to a minimum of 138% of poverty level, regardless of categories. There are, of course, exceptions for that. For a big one, I live in California. A large issue here is issues around undocumented immigrants and also a waiting period for legal immigrants. But broadly speaking, Medicaid is the foundation for expanding coverage. And the private insurance system also plays a major role. That's kind of the next part of the tower. Over the course of the year, states will be developing exchanges with private plans where individuals can, as well as small employers, will be able to purchase coverage. There will be subsidies and assistance to help people cover the cost of health insurance premiums in those exchanges, as well as some of the out-of-pocket cost sharing. And those subsidies are broadly available up to about 400% of the poverty level. And you'll see there's a small share of the uninsured that are above that income level who would likely not receive any sort of assistance. I think it's important to recognize that not everybody, again, will be covered. The sections here on the right side are really just going to give you a portrait of what the income level is for the current uninsured population. Not everybody will qualify because, like I said, there are restrictions, particularly around immigrants. But broadly speaking, we estimate that about half of the currently uninsured population will go into Medicaid. About a third will receive some sort of assistance to purchase private insurance. And I'm moving on to the next slide. So I think it's important to recognize that the Affordable Care Act, while federal legislation obviously is going to be implemented at the states, states will make a lot of different decisions about the details. And I also think it's important to recognize that the impact is really going to vary across the country as well. What you're seeing here on this map is current uninsured levels among non-elderly women by state. And so you have some states that are in the dark red that have more than a quarter of women currently uninsured, and the states in the blue, lower percentages, but still obviously significant. And so, as I mentioned, Medicaid is really the foundation of expanding coverage under the Affordable Care Act mandate and expansion. Last summer, if you think back to then, we were all waiting for what was being billed as the biggest Supreme Court decision of time, or at least in a long time, and there was a lot of focus around whether the individual mandate portion of the Affordable Care Act would be upheld, and a lot of debate about that. And the Supreme Court did rule on the constitutionality of the ACA and its provisions, and it did uphold the individual mandate. The sort of sleeper issue in the case was the expansion of the Medicaid program. And so this is a very sort of condensed version of the Supreme Court ruling, but essentially all ACA provisions do remain in effect, but the court limited the enforcement power of the Medicaid expansion. So essentially, states still have the financial incentive to expand their Medicaid programs with federal financing, but it is not necessarily required. So states who do not expand the Medicaid program are not necessarily required to expand their Medicaid program. So what the sort of shorthand that's been thrown around is that they kept the carrot and removed the stick. So what this has meant in practicality is that not all states will necessarily be expanding their Medicaid programs. And so in states that don't, you are removing that sort of bottom tier of that column, that foundation for expanding the programs. And I think this raises a lot of questions for exactly how women will gain coverage in those states. So I want to go over why Medicaid is already such an important program for women and for preconception health. As you see here on the left, the majority of adults in the program now are women. That's because they are more likely to meet the program's eligibility, both in terms of having lower incomes on average, but also really falling into one of the categorical boxes, of course, pregnancy, but also caring for dependent children. What you see here on the right is that of the women who are in the program, 2/3 are in their reproductive years. And so Medicaid has a long history, as Karen said earlier, of being a women's health program and providing reproductive care, particularly for low-income women. And so I just want to go over some of the sort of most important provisions, many of which I think you all work with. In terms of prevention, across the states, the sort of Medicaid family planning is a mandatory service under Medicaid. There are very few that are mandatory, but family planning is one of them. Family planning also receives an enhanced federal match. So while many services are split the cost is split 50-50 between the states and the federal government, family planning services actually receive 90% coverage from the federal government. As a result, family planning is Medicaid is the single largest payer for family planning services. In addition, cost sharing is already prohibited for family planning services as well as to pregnant women. There's a freedom of choice provision that allows most beneficiaries to seek family planning services from any participating provider. We have actually seen some activity on that in the past year with attempts in certain states to eliminate Planned Parenthood as a provider of Medicaid family planning services. Some of those lawsuits are still going on. Of course, Medicaid in most states covers many important screenings for STIs, breast and cervical cancer, and I will show a little bit of data on that in a bit. Of course, Medicaid funds almost half of births nationwide. In some states, that's more than half. In a couple, it's up around 60%. Typically covers prenatal care screening. And postpartum care in some states only up to 60 days, though. And so this is an important area where obviously the ACA would expand coverage and less women would be likely to lose coverage after the 60 days. And of course, I think it's important to remember that abortion services are actually quite limited under Medicaid due to the federal Hyde Amendment. Like I said, while family planning is a mandatory benefit, states decide exactly what specific services and supplies they're going to cover. We did a survey of states a few years ago to learn more about what they're covering. We got data from 44 states. For the most part, all of the states cover most contraceptives and claim the 90% match on a regular basis for that. What you see is that states are not necessarily always getting the family planning enhanced match, though, for other services such as GYN exams, preconception counseling. So that is an area that I think some states have done more activity on than others. And here what you see is a map that sort of shows that, over the past decade, that how much activity there has been in the extension of family planning programs and family planning waivers, where states extend coverage of family planning services to women who don't necessarily qualify for the full Medicaid program. Right now, we have about half the states that have these. I live in California. We have a very large family pact program. Obviously, I think this is an area where there's a lot of opportunity for preconception care. It is the natural population group. I think this is an area that has, we're going to see some more activity in the sense that in states that choose not to expand their Medicaid programs, I think the role for for at least the family planning programs could be really important. And the major change that happened under the ACA is that states no longer necessarily have to repeatedly apply for a waiver. States can actually amend their state plans and write it into a state plan amendment, and you can see there that a handful of states have already done that. And Before I leave Medicaid, I just want to really emphasize the point that Medicaid matters. The Medicaid program, I think, as we all know, is by no means perfect. Certainly there are a lot of issues around provider reimbursement and finding providers, but what we see is that Medicaid really makes a difference. The data here looks at barriers to care. The percentages in the red bars are women on Medicaid. We still see many women still having challenges accessing care, but as you see on the without Medicaid, many low-income women would be uninsured, where it is much, much harder to access care. And so now I want to turn to the private sector, because that's definitely the next tier of expanding coverage under the Affordable Care Act. What you see here is just a list of some of the major market reforms that were written into the ACA to strengthen and change the private insurance market. We have, like I said, we already have a prohibition on pre-existing condition exclusions for children. The same ban will go into effect for adults next year. We also have the modified community rating, which essentially means that limits the range or limits the number of issues that the variation that insurers can charge in determining premiums. In the individual insurance market, it is still in some states legal to charge more based on gender. That will no longer be allowed next year in all states. There will also be a prohibition on annual and lifetime limits on coverage. And there are some provisions that I think are important that haven't necessarily received as much attention, but around transparency and really the information that is put out to beneficiaries about exactly what their plans cover. And it'll be interesting to see how plans exactly translate that. Here on the next slide, you've probably heard a lot about essential health benefits, and this is the idea that we talked a little bit about the sort of expanding coverage, but then there's the issue of what exactly plans are going to cover. And so the ACA outlined 10 broad categories of coverage, and these are meaning that private plans in the exchanges as well as outside the exchanges, new plans will need to cover services within these 10 categories. In some ways, this package pretty closely matches what is offered by most employer-sponsored plans today. And like I said, ACA is really going to be implemented at the state level. So the details of exactly what gets covered in all these plans will vary by state. States are now in the process of choosing benchmark plans. So that is sort of a minimum level plan that will set the foundation, or at least the benchmark, the floor for what new private plans are going to have to cover exactly under all of these categories. I think it's really worth noting the inclusion of maternity care to this list, because this has definitely been a longstanding gap in most individual insurance policies in the past. And in addition to the essential health benefits kind of working in concert together is the ACA provision for coverage of preventive services. This has received, especially in the past few months, quite a bit of attention. So the ACA basically has required that new private plans, and we also now have the newly expansion population under Medicaid, to be covered without any cost sharing, that is without any out-of-pocket costs, federally recommended preventive services. And so what that means is preventive services that are recommended by the U.S. Preventive Services Task Force, which is a committee convened by the federal government, immunizations that are recommended by the Federal Advisory Committee on Immunization Practices, preventive care and screenings for children under the Bright Futures Guideline out of HRSA, and then the provision that we've kind of been hearing a lot about over the past few months, the Women's Preventive Services. This is a set of 8 services that was developed by a committee of the Institute of Medicine and then adopted by the federal government and these are preventive services for women. My next slide, I'll show you a chart of sort of the full slate. And so all of these services, this is one of the provisions that's already in effect. New private plans need to cover these services without cost sharing. And this is a complicated, busy chart, but it's just to show you, I think it's more important to look at the categories across the top there. There are services that fall into a lot of different categories, many of which are important for women in their reproductive years. Obviously, there's a whole pregnancy-related category and a reproductive health category, but many of the other services under chronic conditions, healthy behaviors are really important for primary care and preconception health as well. Just in terms of the colors here, the orange ones are the women's preventive services that were added. Some of the ones that I think are of particular importance, the one that has received the most attention is the coverage for contraceptive services without cost sharing, but other ones that are really important, breastfeeding supports, obviously, and I think it's also the well woman visit, and in the recommendation from the IOM, they specifically stated preconception care as a service to be included in a well woman visit. And here, this next slide will show you a little bit. I've pulled out some of the pregnancy-related services that are now to be covered by new private plans. So it includes, like I said, the preconception care and the well woman visit, folic acid supplements, which have been recommended by the USPSTF for quite some time now, the HPV vaccine, obviously contraceptive services, but also prenatal visits, tobacco counseling, and cessation interventions, and like I said, breastfeeding supports. And so what I think it's important to realize, and I think Kay might talk about this a little bit more, is the details still really matter. The details will vary by plan. I know some people are not getting coverage for these services already. That's probably because they're in a grandfathered plan. But I think there's a lot of questions also around, for example, breastfeeding supports. There was a good article in the Washington Post yesterday. Exactly how long will supports be covered, what number of visits, what type of pump, rental, et cetera. So, and I think also, again, when it comes to the contraception, there is definitely going to be a lot of variation between plans on exactly the specific services and supplies that are going to be covered. So I think it's really important for people to find out what's covered in their plan. As I'm going to go on to the next slide here, as I mentioned, many under Medicaid, I think, again, I want to reemphasize, many state Medicaid programs are already covering these services, and many are covering them without copays. Obviously, like I said, family planning, that's already required, but many states already cover Pap tests, chlamydia screening, STI counseling, HPV vaccine, already covering them without cost sharing. And of course, and I'm not going to talk about this in too much detail, I think it's important to realize that we are going to hear a lot more about the contraceptive coverage over the course of this year. It is being challenged in the courts, and so as well as on the exemption for religiously affiliated employers. I'm going to move on to the next slide. So I think just again, kind of bringing us back to the big picture, I think it's really important to, as these exchanges get set up in all the states, it's really important to keep in mind affordability. We've got, the guidance around essential health benefits is guidance around exactly, broad categories of services to be covered. But there's still, for many, will be out-of-pocket costs and obviously premium costs. And here what we're just looking at is, many women still do experience barriers to care because of cost. They are worst for the uninsured group. That's the dark blue columns on the right. But even many women with insurance can't afford all the services that they need. So, as exchanges get set up, I think it's going to be really important to look at scope of benefits, premiums, and copayments. And as I alluded to earlier, not everybody will be insured. Immigrants who are not legal residents, some who are going to be eligible for Medicaid but not necessarily enrolled. And there will be some people that choose to pay the penalty in lieu of getting coverage. And so I think it's, as well as, like I said, I think it'll be really important to monitor which states don't expand their Medicaid programs. But this is all to say that I think it's really important to recognize that a really strong healthcare safety net is absolutely still going to be essential. There are, that means public hospitals, family planning providers who for many low-income women have been the main point of contact with the healthcare system. And I think it's also important to recognize that the ACA does have a drop in funding for some public hospitals because of the, it was anticipated that many more people will gain coverage. But in a state that decides not to expand Medicaid, that could be very problematic for safety net providers. And so I just want to wrap up with some of, sort of some big points and some of the questions. I think there are many questions outstanding. Some of the ones that I think are really important for us to think about are just that, states have some really crucial decisions to make. I think it's really, whether they're going to expand their Medicaid program and take advantage of the federal financing for that, what the benefit packages are going to look like. I think it's really, really important for women's health advocates to be at the table, to be working with their exchange boards, and I know different states have different levels of that. And I think, in terms of the details of the operation of the Medicaid exchanges, what steps will states take to improve outreach and enrollment? I think, we do public opinion polling here at the foundation, and what we find is that there are still many people who are unaware of the ACA's benefits, and so it'll be really important to, make sure that people know about it and to set in place the systems to sign up people. And, what exactly will plans cover as preventive services? What will the cost be? And like I said, making sure that our safety net is still strong. And then, of course, there is the ongoing debates at the federal level about our economy. So some of the questions that I think are really important for us to be working on over the next year. And Carolyn, I can hand it back to you.
All right, Usha, thank you so much. That was really informative. And to our audience, thank you so much. We see the questions coming in. I know Usha seemed to cover a lot of them naturally in her presentation, but we are aggregating these on our side, and we'll try and get to as many as we can. So please keep them coming. But without further ado, I'm going to hand it over to Kay Johnson, who will provide an overview of state work and promising strategies to improve the health of women prior to pregnancy and between pregnancies. Kay, I'm handing it over to you.
Thanks,
I think you're
Carolyn.
muted.
Can you hear me now?
Yes, ma'am.
Great. All right. So I am going to talk about, kind of really get a little more into the details of the role of policy and the ACA and the work that states and Medicaid agencies are doing across the country with regard to preconception and interconception care. So I like to start with some of the framing that really the Preconception Health Initiative always puts out and what we've been thinking about over the past 6 or 7 years about why be thinking about preconception and interconception health and what's not happening that should be. So Usha has alluded to a number of these things. Right now we've had millions of uninsured women, 1 out of 5 approximately, that the quality of primary care for millions of women of childbearing age is inadequate, that many providers are not focused on reproductive risks, on preconception health, or on recurring pregnancy outcomes, helping women get to their own reproductive life plan in good health, whether they choose to have a pregnancy or not and when. And there are a lot of prevention messages that are still not reaching women. So in that context, just to say these are some data. I think actually a couple of the co-authors of this study may even be on this webinar looking at 26 reporting areas from the Pregnancy Risk Assessment Monitoring System of PRAMS. What we see is the kind of pre-pregnancy preconception risks and some of the interconception postpartum risks. And you can see both in the case of all women, alcohol use and multivitamin use, that thinking about obesity and non-use of contraceptives. And in some of these, the women in Medicaid have a higher risk. Just tobacco is a good example of that. Lower again on multivitamin use, much higher stress. About the same on contraceptive utilization, but having had a prior low birth weight and so on. So we know that there are a lot of women who have risks that are related to their reproductive health and their own chances of having a healthy baby when and if they choose to. So there has been, I think as most of you know, a National Preconception Health and Healthcare Initiative going on since 2005. a lot led through the efforts of the CDC and also through HRSA, and many organizations, including AMCHP and many states, have been involved in this. We started back then with a set of national recommendations, and I just wanted to remind people that the goals of the initiative around improving knowledge, attitudes, and behaviors of men and women related to their own health prior to pregnancy and reproduction, to assure that all women of childbearing age have preconception care services, particularly including screening, health promotion, and interventions that would enable them to enter a pregnancy in optimal health should they choose to do so, to reduce the risks indicated by a prior adverse pregnancy through what we call interconception care, and to reduce the disparities in adverse pregnancy outcome. The Affordable Care Act obviously provides opportunities, I think really thinking about the life course perspective, to assure that women and men attain good health in childhood and adolescence, maintain it through their reproductive years, and age well as seniors to improve their health. It's going to require our action. Usha did a very nice job of giving you a lot of detail about the Affordable Care Act. I want to re-emphasize just a couple of points. One, around these clinical preventive services, particularly those that were added for the women and the women's clinical preventive services. There are two categories here. One is the essential health benefits that are largely what are going to be covered under plans that are in the state exchanges. The preventive clinical services is a much broader group. And in fact, HHS has estimated that what went into effect on August 1st of last year would affect 47 million women with health insurance. This is not a small number. It's not a side group. It's not just people who are going to get subsidies. It's really a lot of people. And that what the IOM recommended that in the context of those well women visits, in addition to the other things that are here and that Usha gave you more details about, that those annual preventive visit or visits would include preconception care, not just a pre-pregnancy visit, but really that idea that many of us have been talking about for years, that you integrate some of this content, screening, and health promotion into the well woman visits. That it specifically referenced there. It's about there's a lot of questions about the grandfather's plans. We'll come back to that. But I think that mostly to say that there will be, by the time we get to 2014 or 15, there will be very few grandfathered plans. Every time someone reissues or re-ups the policy, they go out of that grandfathered status. And the real question for me, and I think Usha raised this as well, is how can states support the changes that are needed in provider knowledge, attitudes, and practices, along with the consumer awareness to assure that women know they're covered for these services and get the services that are covered. In the work of the clinical work group of the Preconception Health and Healthcare Initiative, issued a journal supplement around the content of care, and one of the things in that content of care supplement is an article by Mary Kay Moose, which includes a very nice list of recommendations about risk assessment and health promotion related to preconception care and health, and really thinking about the context of the well woman visit. And I'd encourage you to look at this slide and maybe go back to the original article if you're particularly interested in this. Mary Kay Moose is going to be working, she has been working and is going to be with the rest of the clinical work group putting forth a toolkit that will help inform clinicians about this, and we're trying to do the same on the policy side. I have the honor of being the co-chair of the Policy and Finance Work Group, and currently Louise Floyd is our lead at CDC. Hani Atrash and his team at HRSA are going to be working on this, and Sarah Verbeest at the University of North Carolina is the primary consultant for leading the initiative. I want to talk just for a couple of minutes about the the peer-to-peer learning project that I conducted with 7 states who were really interested in the idea of addressing women's health and preconception health through Medicaid. One of the things that we did in a year of discussions, you can see this is a diverse group of states. You're going to hear more about Oklahoma's work today, and I'm going to talk about a little bit more about North Carolina and Louisiana. But the fact is that what we generated, which I think is very useful whether you're in a state or a local health department or in another context, is a set of questions that can identify opportunities for states to improve. The big set of questions for me start around how many. And I have found it remarkable that we are not consistently able to answer this set of questions across the country on a state-by-state basis, and we certainly don't have data that we could aggregate nationally, and I think there are many people working on this now. But knowing what percentage of births are financed by Medicaid, what's the standard methodology, are we using it from the birth certificates, are we using it from Medicaid claims data, and then do we know what percent of those women had a postpartum visit? What percentage of them are losing coverage within 60 days? What percentage of them are transitioning after 60 days if they're losing coverage into a family planning eligibility category, a waiver, or a state plan amendment? And how many women have a repeated low birth weight or preterm birth financed by Medicaid? And then really into the very heart of the matter, what are the direct Medicaid costs for that medical care to mothers and infants? If we knew the answers to these questions, we'd be getting a lot more action on the challenges that are facing these families. There's another more detailed set of questions, but the other headlines on this checklist, just in the interest of time, are how can the state improve the quality of primary care and postpartum visits using the evidence around preconception care? How can evidence-based pre- and interconception screening assessments be encouraged by Medicaid? How can states use Medicaid managed care arrangements to improve women's pre- and interconception health? One of our leaders in the country out at Kaiser Permanente in Northern California, and Dr. Jeannie Conry there is the current president of ACOG. I think they've really shown a light on a lot of what can be done, but a lot of Medicaid managed care plans are also taking up this challenge, including AmeriGroup and some others in Louisiana. And how might states use interconception care to serve women who experience a Medicaid-financed pregnancy with an adverse outcome? And really that's the essence of how we've defined interconception care. I'm going to talk more about that through the lens of the Maternal and Child Health Bureau so-called COIN, the Collaborative Improvement and Innovation Network to Reduce Infant Mortality, and my thanks to Reem Gandor, who's been staffing this COIN for sharing some of the HRSA slides. The concept of a COIN comes from Peter Glore and several books that he's written. It's about a self-motivated group of people who collaborate directly through hierarchies, and they get swarm creativity or swarm intelligence, and there's an openness to contributions from all. HRSA AMCHP added to the concept of innovation, the concept of improvement. So that is the network that we're working on, particularly in 13 states across the South right now. This was developed through an ongoing partnership that includes ASTO and AMCHP and the March of Dimes, City Match, the Centers for Medicaid and Medicare Services, the CDC, and other public and private partners. It's team-driven and designed to address the needs that the states have identified, and really growing out of the thinking in the southern states about infant mortality reduction and a plan to expand nationwide. The Southeast and Central South states in regions 4 and 5, these 13 states identified 5 common strategies. You can see promoting smoking cessation, expanding interconception care in Medicaid, reducing elective deliveries, enhancing perinatal regionalization, and promoting safe sleep. There are strategy teams with representatives from federal organizations, national organizations, and states, and within states teams. I'm going to talk specifically about the interconception care and Medicaid strategy team. We've got a powerhouse of ideas here in both in our team leads and our support team. I know that Brent and Cheryl are able to be on the phone with us today, and maybe they'll have more input through the chat later. Back again, as I mentioned, the concept is about reducing risks that are indicated by a prior pregnancy outcome. And so our focus really is around those women who've had a Medicaid-financed birth who have risks that could lead to a subsequent adverse pregnancy outcome. So we've been talking about a group of pregnancy outcomes that have some future predictability and prevalence, and so fetal and infant mortality, preterm birth, low birth weight and very low birth weight, and some of the most prevalent maternal complications are the things that have been most under discussion through our COIN. We've kind of developed this pathway approach. States before the COIN were really thinking about the waiver. The prime advantage in the waiver is to expand eligibility. Given that 2014 is such a short time, we did not see that states necessarily needed to go forward with a waiver, but that they could begin to figure out what were the strategies for women who had continuing eligibility. And we're encouraging them to define the criteria. So what are the outcomes and the characteristics of the women who would qualify, and what is the kind of case management approach they might be using. So it might be targeted case management or primary care case management or care coordination in a health home. It might be chronic disease management, and then determine what health delivery system opportunities they have through managed care or medical homes or integrated delivery systems as examples. The states have identified a set of what we're calling the almost shovel-ready projects, with a postpartum visit as a gateway, with case management, with screening assessment, with integrated care models, with the health home for individuals with chronic conditions, and changes in billing codes and provider manuals. I've got a set of these. I'm not going to spend a lot of time on them. I'm going to do sort of one example here, just that a state might extend their prenatal case management for 1 year to women with continuing coverage when they experienced an adverse outcome. And another set on postpartum visits, a state might convene a provider learning collaborative to increase the utilization and quality of postpartum visits among all women who had a Medicaid-financed birth or among one of these targeted groups, or they might do some monitoring of utilization and give some QI feedback to those providers. Another set of things related to these health homes for chronic conditions, which is an option that became available to states under the Affordable Care Act. It's been in effect since January 2011, and there are a number of states that have applied for these. They can elect to target individuals with higher numbers or severity and waive comparability, so they might identify this group of women as a target. And for certain services, and particularly the case management and follow-up and referral aspects of this health home model, states can receive a 90% match. We think this is an opportunity really all across the country for states that are thinking about these to include a specific focus on women with a prior adverse outcome and chronic conditions. I just want to close by mentioning that the recommendations for HHS action from the Secretary's Advisory Committee on Infant Mortality were presented to Dr. Howard Koh, the Assistant Secretary for Health, and are about to be transmitted to the Secretary. I have the honor of chairing this group, and there are 21 people who have spent a lot of time over the past 2 years thinking about what are the things we really need to do now to reduce infant mortality. And just to give you the headlines, and really for the purpose of saying to you that the #1 strategic direction in our 6 big ideas is about improving the health of women before, during, and beyond pregnancy, and assuring an access to a continuum of safe, high-quality, patient-centered care as we go about that. And you can see here another set, and I'm not going to go into those in the interest of time, but only to say to you, whether it's at the level of the coins and learning in the Southeast, or states across the country that are thinking about Medicaid, or thinking about the implementation of the Affordable Care Act, or really digging in on the next generation of opportunities to reduce infant mortality as well as to improve women's health, we see a lot of opportunities. So back to you, Carolyn.
Okay, thank you so much. That was, again, very informative and taking Usha's information to another level. So next, without further ado, I'm going to hand it over to Jill and Shelley from Oklahoma, who will share their successes, challenges, and lessons learned from their state in implementing preconception care. Jill and Shelley?
Thank you. We're glad to join you today, and thank you for joining us. Excuse me. We'll get started with I'm sorry. I'm Jill Nobles-Botkin. I'm going to start out, and Shelley and I are going to share in the presentation, and we'll just flip back and forth based on the slides and our knowledge and which slides that we're experts on. So I'm sorry. I will start out, and maybe you might have to remind me how to advance my slides because they're not advancing for me.
Jill, if you'd like, I could do it for you, but there's also the button down at the bottom, the next. Do you see it? Okay, I can just advance them for you. Just
okay.
Let me know when to move them forward.
Our next button didn't come back up there. Okay, thank you. I wanted to start out by providing you with an overview of Oklahoma as a state. Our population is nearly 4 million, and we're divided racially and ethnically by 72% being white, 7.5% black, and 8.5% American Indian. You can see that a majority of our population, or half of our population, falls within the reproductive age. A little more than half falls within the reproductive age group there. And women of reproductive age, you can see we have 736,629 females in what we consider reproductive age, which is 15 to 44 years, which compromises about 19.6% of our population. I'm employed by the Oklahoma State Department of Health, and I work in the maternal and child health portion of the health department. MCH in our agency covers child and adolescent health, MCH assessment, which is our epidemiologists and our analysts, and then perinatal and reproductive health, and those are the programs that I oversee. Okay, I can't see my slides, but I'm going to go ahead and talk, and hopefully you can see our slides. In 2011, those served under Title V included 79,930 pregnant women, 64,796 infants less than 1 year old, and 621,819 individuals 1 to 22 years old. I also oversee the Title X program, and with those funds and additional state funds, we served 59,452 males and females.
Hi, I'm Shelley Patterson, and I'm with Oklahoma Healthcare Authority, and thank you so much for having me today. I'm very excited to be here, and like Jill said, we'll kind of go back and forth, and we had a technical issue, but I think maybe we've got our control back of our slides, so we're going to try that. So as you can see, Sooner Care is the name of Oklahoma's Medicaid program, and we serve about 1 in 4 individuals in the state each year, and you can see that last year, during our last fiscal year, we served over 1 million individuals in the state, the majority of those, or more of those, being female than male, and the greatest majority of our population being children. And you can see there, the pie chart shows that the largest proportion there is children, close to 60%, and the adults of childbearing age would be in the group that's in the 36%. And then our racial makeup is similar to the state of Oklahoma as far as our Caucasian population, with slightly higher rates for our African American and American Indian populations. And then as far as pregnant women, we do cover about 2/3 of the pregnant women in the state, and some of those may be covered through additional insurers, but Sooner Care does cover at some level 2/3 of the women in the state. And you can see the next chart shows kind of throughout the years, the last several years, comparing the number of deliveries in the state of Oklahoma and those that are covered by Sooner Care.
So back in 2005, leadership at both the Health Department and the Health Care Authority established a joint perinatal advisory task force, and then a couple years later the Child Health Advisory Task Force was also created. The task forces function as advisory groups for both the Health Department and the Health Care Authority on issues concerning health and health care for pregnant women and children covered by Sooner Care and served by private and public providers. The groups serve to provide expertise regarding perinatal and children's health and to make recommendations regarding policy and system changes that can contribute to improving health outcomes for pregnant women and children. So they serve as, or they assist both agencies in developing and improving policies and services for Oklahoma's low-income women.
And I'll just chime in. It says here that it was established in 2005, and back then, kind of what was going on in the state, from the Sooner Care perspective, our pregnancy care benefits were not as rich as they are today. And we were hearing from providers that there were certain needs for coverage, and we got together with the folks at MCH, the Health Department, to sit down and discuss the needs for the state. And we both decided that what we needed was to hear from a richer group of individuals throughout the state. And that was really sort of what was the basis of our Perinatal Advisory Task Force, that we really felt like these groups needed to come together and kind of advise us on what's going on a daily basis out there in the communities, out in providers' offices, in the homes of these women, the kinds of needs that they were in need of. So that's what was the basis of the perinatal advisory and how we got started.
So we talked a long time about who all could possibly be touched by these services or help provide these services. So the next couple of slides provide you with just a list of the entities, organizations, providers that we felt like it was important to include in these task forces. Include OBGYN providers, nurse midwives, pediatricians, nurses, the Oklahoma Family Network and Institute for Child Advocacy, our family physicians, Hospital Association, nurses, Osteopathic Association, Primary Care. So I'm not going to read them all off to you, but just so you can get an idea of how broad a group this is that we decided needed to have input in these task forces. We have a leadership team that serves as a steering committee for these task forces that includes representatives from Maternal and Child Health, the Health Care Authority, our Office of Perinatal Quality Improvement, the March of Dimes, the Hospital Association, and our Oklahoma Family Network.
And this group kind of acts as a supplement to the advisory. It's kind of a interesting collaboration that we get together on a regular basis, but at least monthly, individuals from each of these organizations, and discuss the issues that the task force brought to the table and other issues that are going on in the state.
And we help through these meetings prioritize which issues need to be addressed first and how we can address these issues with all of these leaders.
And so as a result of really kind of the task force recommendations and holding meetings with all of these various organizations and individuals throughout the state, these are some of the things that resulted as that collaboration has grown over the years. And we won't go into depth into all of these. Many of these are benefits that are related to pregnant women that are available through Sooner Care, probably the first several bullets there. And these were, like I said, some of the things that in early 2005 were not covered, and currently women can go to their obstetric care providers, and providers can get some reimbursement for prenatal risk assessment when they conduct psychosocial assessment in addition to the the routine medical assessment. We also got benefits in place for first trimester ultrasounds because those were found to be very important. Our OBs expressed that, and we were able to get those benefits put in place. The perinatal dental benefits was really our first step toward any kind of adult dental benefits, and several thousand women have been able to take advantage of those benefits during pregnancy. You can see there also we've got just a wide array, social work services, lactation consultation, tobacco cessation. These were all things that were really expressed as needs through this task force that was formed, and we were able to really sit down and develop a quality package, a much richer package of benefits for our pregnant women.
We also heard from professionals and nurses and physicians who wanted to make some changes in the hospital, for instance, like reducing elective deliveries prior to 39 weeks, that they needed some support. Some hospitals don't have a large staff, and if you have one person that doesn't want to conform or move forward in adhering to national standards, it can be difficult. So we found ways to support hospitals related to their efforts to improve quality care. The group also served as an advisory for the health department as we looked at the Title V needs assessment and helped us identify priorities to focus on for our state performance measures for the Title V needs assessment. And also a major accomplishment for us, which took a lot of effort on from both agencies, was movement from the family planning waiver to the state plan amendment, and I think that the benefits of that have been outlined already, that we were happy with that accomplishment. But task forces are generally intended for targeted short-term projects, and if you remember, these task forces were developed in 2005, and so we this year decided to look at where we were and maybe where we needed to go, and decided that it was maybe time for a change. And so we talked with the members to get their input and looked at how to transition the task force to more of a state-level perinatal coalition. We felt like traditionally, the leadership for the task force has been from the two agencies, the Health Department and the Health Care Authority, but in order to evolve and transition to a more of a state-level coalition, leadership needs to expand beyond these two agencies. And we really wanted to include physician leadership and elicit more physician input. So both agencies still need these, both the perinatal and the child health advisory groups, to provide that service, to be an advisory group, but we also need to have buy-in from those providing services in order to make changes that benefit everyone. So we need ideas from the public and the private sector on issues improving quality of care. So we ran into some challenges identifying physician champions. Sometimes it's difficult to stand up to your peers if you're advocating for something that's not popular. We also, but we were, I will say, we have been successful in identifying physician champions who are willing to take over leadership for the task forces, and we're very excited about that. We're just in the process of evolving right now, so we'll have to get back with you and let you know how that works out. Other challenges were coordinated administrative support. When we started trying to look at leadership that was from outside of these two agencies, then we had to determine who was going to provide the administrative support. And also a challenge is listening to the needs of individual members. Sometimes there can be very different needs based on whether they're in a private office or whether they're in a public office, or we've found that some physicians don't like to be told what to do, and yet they're not practicing within generally accepted national standards of care. So, and sometimes the priorities are different for different providers. So those are some of the challenges that we're facing, but we are excited as we move forward to transition this to a more state-level coalition. Now we're going to move beyond the task forces just a little bit and look at some of our other joint activities that we're involved in that focus more on preconception care and improving infant outcomes and reducing infant mortality. Preparing for a Lifetime, It's Everyone's Responsibility is an initiative to reduce infant mortality. It started in response to high infant mortality rates in Oklahoma, and the Commissioner of Health at that time convened an action team, or asked us in NCH to convene an action team with overarching goal of reducing infant mortality. It was charged with developing a strategic plan outlining specific steps to be taken to reduce infant mortality and other adverse outcomes, as well as reduce racial disparities. This team first met in 2007 and spent a couple of years trying to identify what areas to focus on. I think that you may have gotten the impression already, or probably most of you listening know, that preconception health and interconception health encompasses a whole array of behaviors and health risks, and it's difficult to focus on just one area or two or three areas. So after reviewing data, we decided that the work groups were going to be developed based on the topics that you see on your screen. We felt like these were the most important things that where we could affect behavior changes. Some things you can't change, some of your risk factors you can't change, but we felt like these were areas where we could affect change in behaviors. And so we chose these work groups to address the infant mortality issue. The first and basis for the work group was the preconception, interconception, health, education, and care work group, and I am the lead for that one. I can say that another example of where we partner is like for the preconception, interconception work group, Darren, who is from the Healthcare Authority, and I jointly co-chair that committee. The prematurity work group is led by someone from the Office of Perinatal Quality Improvement. The breastfeeding work group is co-led by MCH and WIC. And Infant Safe Sleep and Injury Prevention have representatives from our Child Death Review Board and our Injury Prevention Service. So that just to name a few and show you ways that we partner in this initiative also. I added this slide in there about talking about the COINS groups just as interest. Kay explained what the COIN groups were, so I won't go into that. But just so you see that the group that, or the states that are involved in these groups identified the same types of issues that we identified for our infant mortality initiative. And so I just wanted to point that out, that what we started working on several years ago, whether that's good or bad, I don't know. We still have the same issues a couple of years later, but at least we're working on the same goals. To bring it down to the state level, the preconception, interconception activities that we're working on right now are or have been working on in our finalizing our development of tools to be used to help providers enter into a discussion about preconception, interconception activities, or reproductive life planning. The first one that we worked on, which is almost complete, is a women's health assessment. And on the left you can see what the front page looks like. And then the rest of the little booklet is color-coded. The different color bars that you see on the right-hand side are different areas like your family history, your OBGYN history, nutrition, and so each of those is a different category. And then the following pages are color-coded too with the answers. This is like a check sheet on this first one with all the colored bars is a check sheet where the client will go through and check which risk factors they think they might have, and then the rest of the booklet is intended for the provider to use to help explain to them why those risk factors are important and what they can do. And that has been piloted and has been is in the process of being updated so that we can use that in both the public and the private sector. We also have been working on a reproductive life plan for adolescents, and I have to give credit to Delaware because we, with their permission, stole what they had created. They had used focus groups and found it to be what their adolescents needed, and so we also did some piloting and some convenient samples of adolescents. We used them to determine if it was the most appropriate thing for Oklahoma adolescents, made a few changes, and now we are using, or we're actually piloting this with adolescents right now. And also, Shelley's going to tell you about another way that we're using this reproductive life plan. We are also working on a men's reproductive life plan tool to try and help men realize how important they are in planning for pregnancies and also making behavior change choices. We have already done one public service announcement focusing on the choices that men and women make today and how important that is someday when they decide to have a baby, if and when they decide to have a baby. We thought we were ready to do a second public service announcement, and focus group testing showed us that people thought they'd already heard the message before. So we went back to the drawing board because, like we said, a lot of other topics are part of preconception health: smoking, obesity, nutrition, physical activity. So they were right. They have heard the information before. So we need to go back to the drawing board and look at how to present this information in a way that they understand that, even though they've heard it before, it is definitely an important part of preconception and interconception health. We do provide family planning services in most of our counties in Oklahoma in our health department. We are the Title X grantee, and so we provide family planning services. And as part of that, in this talk about partnerships, we have eligibility analysts in many of our county health departments who help our clients sign up for Medicaid. And we've been very successful at signing clients who didn't even realize that they qualified for either the state plan amendment or for full Medicaid. And we've been very successful at increasing the numbers of clients covered for that and increasing their options for care.
And Jill mentioned that the My Life, My Plan adolescent tool is also being used, that we're kind of working in cooperation. Some of you may know Medicaid agencies are basically required for children that are covered. They are required to provide coverage for well child screenings and kind of keep statistics and numbers on how many kids are presenting and for what kinds of screens. And it's really interesting when you look at the rates of screenings for children, they're very high at birth, and you can just see the line sort of decline going downward every year as they get older. And by the time that they're adolescents, they're really not going to those appointments nearly as often as we would like them to. And so we were really looking at adolescent care as an opportunity to sort of for preconception health, in that while children are covered through Medicaid, we'd like for them to be as healthy as possible, and when they enter those reproductive years that they're approaching. And so we really wanted to try to obviously increase our screening rates, get more of those children into their providers' offices, and also improve the quality of the visits when they do present at the offices in regard to preconception health. And so we have partnered with one of our university's our Department of Family Medicine to actually go out and work with primary care practices to try to implement evidence-based best practices around adolescent screenings and adolescent well child visits. And so as a part of that, we're using the reproductive life plan that providers have the option to use that with their clientele, and they are actually going out into school districts and working with school districts as well for those that wish to partner on this project. So we're really excited about the opportunities there that to increase those rates of screening. And then additionally, I'll start talking a little quicker. It looks like our time's getting close. These are some of the other activities that our two agencies really have worked together on. There's a shared data work group where the State Health Department actually employed an analyst that would really look at joining together Medicaid claims data with vital records data to try to develop a large data set for our pregnant women and their newborns. And so we've begun matching the mother's Medicaid claims and records, and then we'll get to the babies. And in the end, this will start in 2005. We will have a very rich data set from 2005 forward that we can really examine to see what are the health outcomes or the trends and the gaps, the needs. We're really excited about the opportunities that may come as a result of this data project. And so that's something that's in progress. We haven't been able to really get to the point of analyzing the data yet, but we're getting close, and so we're getting excited about that. The High-Risk Infant Mortality Project is a project that the Healthcare Authority's Care Management Division really took on as a result of one of our state's fetal and infant mortality reviews, put out a report that showed the 10 counties in all of the counties, showed the infant mortality rates for all of the counties in our state. And we were able to look at the 10 rural counties with the highest infant mortality rates and develop a targeted case management program in which all of the women who are enrolled due to pregnancy receive care management for their pregnancy and postpartum, and then for the first year of their baby's life. And so in the end, we'll have lots of data from that as well. There's a large amount of data on outcomes being collected, and so that is really going to be interesting to look at. And then tobacco cessation, we've been working on for some time. We have a project, again, in coordination with another one of our state agencies, the Tobacco Settlement Endowment Trust. They manage our state's tobacco settlement funds, and we were able to collaborate with them to develop a couple of different initiatives regarding pregnant women and women of childbearing age. The prenatal initiative is just about to wrap up after 3 years, and that was really to try to change provider behavior and to implement best practices for tobacco cessation into their practice and get those women referred to our Oklahoma Tobacco Helpline and connected with other resources for quitting. And then the Sooner Quit for Women campaign was a media campaign, and this was a project that Massachusetts that we borrowed from them. And Jill, you can click on the next slides. And these are just examples of some of the media that were produced. These were actual Oklahoma women that we went out and tried to find women with stories about quitting and being successful with their quit attempts. And we've sort of plastered the state with billboards, and we've also got a number of television commercials, and these ads are just appearing all over the state, and radio as well. So those are just some of the things that we have been working on. And then we, as far as, kind of moving forward, our state has chosen not to expand the Medicaid program at this time, and so, looking at that, you can see over the years we've been able to expand some services, and we will just continue working down that line. And one of the things that Kay mentioned earlier was that through the Preconception and Interconception Coin Group, that there's a number of areas that states could look at and try to look at those, what she called shovel-ready projects. What do we have going on that we can sort of make use of today? And so we looked at the initiative that I just talked to you about, the FEMA initiative with the high infant mortality rates in those rural counties, and thought, well, what could we do with that? And sort of in conjunction with the adolescent project that I mentioned before, and then kind of bringing those two things together, we felt like in those counties we could look at our adolescent population and continue care management for those adolescents. Once they gave birth, they would get the care management for their babies for the first year, but we would continue on with care management for those mothers as long as they're covered up until they age out of Medicare, or I'm sorry, Medicare, Sooner Care. And so that was really the project that we thought might make the most sense for our state, and so we're moving forward with developing plans for that. And then there are some other things that we've talked about over the years and that we would like to see: tobacco cessation counseling and postpartum depression screenings as a part of the pediatric visits. These are things that we have been talking with CMS about over the years, and CMS, the Center for Medicare and Medicaid Services, or the federal agency that oversees Medicaid programs. And we are hopeful that at some point they would agree that that would be an important service for reimbursement. So we will continue to work on that. Pregnancy medical home is something that we have also been looking into, opportunities for that. I've recently had conversations with our friends from North Carolina, and we're very interested in maybe developing some version of that at a later date if we have the opportunity. Member incentives is another area that we've been very interested in and we will continue to look at. And then our state is always interested in various opportunities. We have a Strong Start application that we're awaiting the response, and we're hopeful that maybe we'll get to move forward with that. And that really has to do with expanding. I'm sorry. Oh, I thought I heard somebody. Anyway, so I'm sorry. That is really what we are looking at. And do you want to go to the next one? Okay. Yeah, and really on this slide, this is kind of our touchy-feely, I guess, wrap-up that we kind of have just talked a lot about Oklahoma's collaboration between our two agencies, and we just wanted to put this in there just to give hope to any other states that are trying to work together between, say, their health departments and their Medicaid agencies, and that you know, you really can make it work. And Jill, I don't know if you wanted to say some words.
Yeah, I'll jump in. I know when I've been at national meetings that a lot of times I hear states representatives complaining about how that they don't have a relationship with the Medicaid agency, and so I'm very, very grateful that we have a close relationship and we can just pick up the phone and call each other and talk about issues. So I want to say that one of the lessons that we learned is that if you would like to improve your relationships with your Medicaid agency or your health department, be the one to reach out. Take the initiative and identify some common problems and needs. You get a lot farther when you can identify like the common problems and needs rather than just what can you do for me, but how can we work on this together to accomplish some goals that will help us both out. And as you saw on the slides where we listed all of our partners and our people that are represented in the task forces, you really have to think about relationships and who all can be touched by your activities or who all is affected by decisions that you make, and build relationships. Don't just rely on email, rely on personal touches like telephone calls or going over and visiting somebody that you need as a partner. Emails are quick, but the personal touch we have found out works a lot better sometimes if you really want someone to participate.
Well, Shelley and Jill, sorry to interrupt the last moment there, but we wanted to make sure we got a few questions in before the bottom of the hour here. And so, Karen, I wanted to kick it over to you to field a few questions.
Sure. Okay. Thanks. Yeah, thanks very much, Shelley and Jill. It was really a wonderful and rich presentation, and I think Oklahoma is an excellent example of a state where you can get a lot done between Medicaid and public health. And clearly, as you mentioned, that you're a state that's not going to expand Medicaid, at least not now, and yet you've been able to do a lot so far, even prior to the ACA even being passed. So just many kudos to you all for all that great work. We have a lot of questions, and so and we're not going to be able to get through all of them in the interest of time. Just to remind everyone, the slides will be posted as well as the audio recording, and you'll get that email. And I guess because we're short on time, I guess I want to ask of all of the presenters, if you had to give kind of your top 2 to 3 takeaway messages for those folks who are thinking about this work, wanting to improve it, thinking about all the policy issues that are available or even programmatic ones, what would be your recommendations in terms of kind of your top 3 takeaways for states or community organizations interested in this work? And I'll start with Usha, and you touched on some of that in your presentation, but if you could kind of leave us with those thoughts from you, Usha, and then we'll go to Kay.
Yeah, well, I think maybe just building on the model of Oklahoma, I really feel one of the areas is certainly there's the importance of Medicaid, and we've talked a lot about that today. But like I said, the private insurance sector is another huge building block here. And so I think that as exchange boards are doing their work in states, and I'm in a state where we have a very active exchange board that's been going for a long time, but I really think that reproductive health and women's health advocates need to be at that table and raising these issues, what is exactly going to be the scope of coverage and submitting comments. And then on the flip side, the last point that I raised was really making sure that we pay attention to what happens to those who do remain uninsured. And, I think safety net providers and empowering family planning clinics in particular to also be at the table.
Great, thanks. Kay, what are your thoughts here?
Well, I think that agree with Usha about balancing kind of the public and the private side. And so I just say, number one, really getting this information to providers. We're behind the curve on this. I think every state ought to have some kind of a quality improvement project going on that helps to educate providers about how to incorporate preconception screening and content into well woman visits. It's 47 million women. We're not going to get to those women unless we get to those providers, and the new toolkit that's coming from the national initiative this year should help people do that, but a lot of you already have the knowledge in place to get ready to go on that. The second one, I think, is to remember that you don't need a waiver to reach the women who continue in Medicaid. And I think we've had this attitude, which is saying we wanted a waiver to expand the population, but somehow we've missed the point that even if it's women below 25% of poverty who continue on, and those women had a prior adverse outcome, aren't they among our highest risk women? Isn't it just fine to start there and put pieces into place and hold, again, our managed care organizations, our Medicaid agencies, and our providers accountable for delivering more effective services and case management to those women? And third, last but not least, the idea that we have really got this Women's Clinical Preventive Services opportunity window and beyond the exchange plans in every one of your states. So figuring out how you promote that to women might be a really good role for the health department. The National HHS Office of Women's Health has done a little bit around this, but I think every state could help there too.
Great. And Shelley and Jill, what are your parting thoughts here in terms of you mentioned some of those in the closing of your presentation, but any other thoughts for states or community-based groups working on these issues?
Well, we just, it's kind of like that last slide that we were talking about, that, don't give up and get together with your other state entities. That we just feel like that was so key here, that having all of these folks together at the table has really given strength to so many of our programs and projects, and we've been able to move forward in ways that we never would have imagined, that I don't think we could have done if we had each just been working at our individual agencies.
Great. Well, thank you all. I'm going to turn this over to Carolyn in a minute. I just want to say that we didn't get to all your questions, and we apologize. As always, there's so much to go through and not enough time. But I will say that as part of when we post the presentation, we're going to ask if the presenters would be kind enough to allow us to put their contact information up there, so that if you have some burning follow-up questions that you really want to get answered, that you could contact them directly. And on behalf of myself and AMCHP, before I turn this over to Carolyn, I just want to thank all of our presenters for just a wonderful presentation. Carolyn, back to you.
Thanks, Karen. And again, I'm just echoing Karen's thoughts and thanks for everybody. And I'd like to also thank the Kellogg Foundation for their support for this work. And we hope that you found this to be value added for your work, and you'll be able to share the information with your colleagues. And again, just as a reminder, the webinar was recorded, and a link to the recording and the speaker slides will be posted to the AMCHP website next week, and you'll receive an email when that happens. Finally, AMCHP will soon be releasing a policy brief on the opportunities in the Affordable Care Act and featuring some of the State Action Learning Collaborative work. Please look for that policy brief in the coming weeks. And additionally, AMCHP has other resources on this and other topics related to the Affordable Care Act on its website at www.amchp.org. Have a great rest of the day and Happy New Year. Goodbye.